staffed by people who are skilled and properly trained and certified. How would a patient, how would someone who wants to get information knows whether the people are certified and certified by whom and all that? Can you tell us a little about that?
I can. There's an organization called the American Board of Genetic Counseling, and people who are doing this work actually go to graduate school to get training in genetic counseling, and then they have to sit for a certifying exam in genetic counseling, and they have to continuing education units to keep this certification, because as you can imagine, the field of genetics changes every day. And so if you want to know which genetic counselors in your area are board certified, you can go to the National Society of Genetic Counselors website at nsgc.org. Or you can
nsgc.org,
or you can Google National Society of Genetic Counselors, and that website will come up. And on that website, there's a section that says Find a Counselor. And you can put in the city or the state, and it will steer you toward a genetic counselor in your area. I should warn you that a lot of people use the term genetic counselor pretty loosely. Oh yes, we have a genetic counselor at our center, and what you learn is that that person has received a few hours of training from the company that owns the patent and sells the kits. That's not the same as a graduate education, and it's a very biased education.
I see. Okay, so it's important that we make sure that we are being serviced by people who are skilled and qualified to do so. After the family history has been taken, what's the next step in the process of?
So once we take a detailed family history, some of the work is done behind the scenes. And so the genetic counselor takes a look at the entire pedigree. We present it as part of our weekly meeting with an extended team. And we see if the cancers in the family look like they're sporadic, or if they look like they're being passed down in the family, potentially based on a genetic mutation or change. That's the second step. And then we meet with the family, and we discuss, it looks like the cancers in your family are hereditary and you might qualify for a test, or it really doesn't look like the cancers are hereditary, we don't think you need testing. And we talk about the risks, the benefits, and the limitations of this testing.
Okay, we're going to come back and speak a lot more about the risk and benefits. You're watching 21st Century Conversations. Our conversation this evening is about cancer genetic counseling and testing. And my guest is Ellen Matloff, and she's a director of the Center for Genetic Counseling and Testing at Yale School of Medicine.
Yes.
Okay. And we've been talking about the importance of knowing your family medical history, especially when you're diagnosed with cancer at an earlier age than is normally expected. That by knowing your genetic family history and by going to a center where people are properly trained and qualified to counsel you, this can be enormously helpful in helping them to map the sort of a genetic codes that are in your family, and then you can be advised or counseled about how to proceed after that. So Helen, tell us, what are some of the risks and benefits of counseling or screening and then counseling?
So let's start with the risks. One of the risks of having genetic testing, as we've talked about, is the risk that your test will be misinterpreted. I would say that's the greatest risk. There's also a risk of insurance discrimination. We have been very concerned in the past that a health insurance company could drop someone if they learned they were at great risk. We're not as concerned about that because we have local and national laws protecting against genetic discrimination. But for people who are going out on their own to buy their own health insurance, it could be a risk, and it's definitely a risk for life insurance and disability insurance. And for most people, the benefits outweigh the risks, but as part of the counseling session for the average person, especially a person who's never had cancer, it's important to know both the risks and the benefits.
Now, when you're going out to buy insurance, is this because this is sort of considered a pre-existing a pre-existing condition, if you have, these genes, that means you're predisposed to having some types of cancer?
Well, the good news is everybody has at least 10 or 15 genetic mutations for something. Maybe it's heart disease, maybe it's high cholesterol, maybe it's premature Alzheimer's, maybe it's obesity. And I think that as genetic testing unfolds, there will be a day when we're going to go in for genetic testing and they'll test the entire genome and tell us you're at risk for the following 30 things. I think that will help to even the playing field. At this point in time, particularly if someone learns they're at high risk for cancer, we're concerned that if they go out to buy life insurance, the life insurance company, you sign a waiver allowing them to look at your medical records. And if they see you're at high risk for cancer, they may determine that you're at high risk and that they won't offer you life insurance, or that you'll be offered it at a higher premium.
Knowledge is power.
Knowledge is power.
If you are informed and you understand what you're dealing with, you can take some proactive steps. And what are some of those proactive steps that you would suggest?
So there are several proactive steps. If a person learns that he or she is at increased risk for a certain type of cancer, we're going to begin surveillance at a younger age, and the surveillance is going to be more aggressive. So let's use the example of breast cancer. We're not going to have a woman who's at high risk have her first mammogram at age 40, as we would for a woman in the general population. If she carries a mutation, we offer her surveillance beginning at age 25. And although currently we offer her a mammogram, we're kind of leaning now toward breast MRI, a new technology that is only offered to high-risk women. So that's option number one, would be close surveillance at an early age.
So the breast MRI is offered only to women who are at high risk.
That's right, currently.
And this is because the MRI will pick up very, very minute size, little pits they call them, as opposed to waiting until they're tumors.
And that sounds great, right? It sounds like, then why wouldn't everyone want a breast MRI? But the problem is that a breast MRI is so sensitive that it picks up tiny little dots that then may require a biopsy, and many of those biopsies end up being benign. So we don't want to offer a breast MRI to everyone because it would result in a lot of fear, a lot of breast biopsies that are unnecessary, which creates scar tissue and a lot of other problems. So we only offer it at the moment to high-risk patients.
And the high-risk patients, again, are those who have the BRCA1 and 2 and maybe this P53 and other markers that say that they are highly predisposed.
Or it may be a person in a family where there's clearly hereditary breast cancer and we can't find the mutation because our testing is not perfect. We still can't find every single mutation. There are some families that are simply uninformative. Someday we'll maybe find that mutation, but we haven't found it yet.
Now, when you say it's in family, for example, you're talking about a case where you have 3 or 4 sisters. I was just watching a program when there are 6 women, 4 women in the family and 2 men. One of the men have breast cancer, 3 of the women, and there's only 1 family member who has not been diagnosed yet, or is not being diagnosed. Now, if that person has not gotten tested, but all these other members do have these predispositions or these markers, this person would be someone to be put on the MRI if she wants it.
I would actually suggest that that person have genetic counseling and testing first, because if she does carry the mutation, then we should follow her with MRI. If she does not, then we don't need to. But keep in mind, surveillance is only one of the options. The other 2 options include something called chemoprevention, not to be confused with chemotherapy.
Yes, tell us what is chemoprevention, because I read about that.
It's taking a medication that can reduce your risk of ever developing certain types of cancers. So for breast cancer, for example, we have a medication called tamoxifen, and another medication you may have heard of called raloxifene or Avista. And Some women at high risk can take these medications to reduce their risk of ever getting cancer. One of those medications, Evista, was originally created to reduce the risk of getting osteoporosis. And so for some women, it can do both of those things. That's the second option. The third option is the most drastic, and that is that some people who learn that they're at high risk to develop certain types of cancers may choose to remove that part of their body preventatively, whether it be a thyroid, it could be breast tissue, ovarian tissue, a uterus, so that it reduces their risk of ever developing that type of cancer.
And those are when we hear about who have had bilateral mastectomy, although they have not been diagnosed with. How accurate is the prediction? Because that's a drastic step.
It's a drastic
for a woman who is
step.
healthy at present to have bilateral mastectomy. And this means removing both breasts, although neither breast have been found to have tumors in them as yet. How accurate is this testing?
So when we learn that someone carries one of these mutations, their risk to develop breast cancer is somewhere between 50 and as high as 85% over the course of a lifetime. Is it 100%? No, it's not. But what I've learned from patients in doing this work now for 15 years is that for some men and women waiting to develop cancer in a family where generations of people have developed and died from cancer, the waiting around and having continual screening and biopsies and waiting, it's too difficult. They would rather have that organ removed and have reconstruction.
Yes.
Rather than live with that fear. And for some types of hereditary cancer, like cancer of the thyroid, there are mutations in which the risk of getting cancer, if you carry that mutation, is virtually 100%. And you can live without a thyroid gland. And ask anyone who's had cancer, if you could avoid getting that cancer, they will say to you, I wish I could have avoided getting the cancer.
Okay. Before I ask you another set of questions, what I'd like to find out from you, is there any one or two specific things you think that our viewer absolutely must know or should know about this that you want to share rather than responding to a specific question?
I would say for viewers out there who are scared and who say, gosh, this sounds terrifying, I just don't want to know. Sticking your head in the sand won't make a mutation in the family go away, unfortunately. And if you come in for genetic counseling by a qualified professional, you can just talk about your options. You never have to get a test. And I would encourage you to at least find out what your options are. You may find out that your risk is lower than you think it is. You may find out that your risk is higher than you thought, and there's something you can do about it. So remember, knowledge is power.
That's one of my favorite phrases. In fact, a part of the motto for OneWorld that produces this program is, it is better to light a candle than to curse the darkness.
I like that.
Yes, because if we're informed, we can make good decisions. When you're groping around in the dark or burying your head in the sand, sometimes when you do come up for air, you find that what you thought would be there is no longer there. Okay, do doctors rely on the results of genetic screening in making determination about treatment?
Absolutely. And this is one of the exciting things about genetic medicine today, is that we can use the results of genetic testing to make personalized decisions about treatment for cancer. So 20 years ago or 30 years ago, if a patient had breast cancer, there might have been a path that every single patient followed. And they might have a lumpectomy plus radiation plus tamoxifen. Now what we know is that if a patient carries one of these genetic mutations, maybe instead of having a lumpectomy and radiation, maybe that patient would be a better candidate for a bilateral mastectomy with reconstruction. Maybe she should also consider at some point in time when she's done having children, having her ovaries and fallopian tubes removed preventatively. This is personalized medicine, and the new director of our new Smilo Cancer Center is really committed to personalized medicine, and genetics is a big part of that.
I see. So, because we're hearing a lot more about genetic counseling and testing than we did even 5 years ago. We're hearing a lot more about it now.
And you're going to hear a lot more about it in the next 5 years.
Okay, in breast and ovarian cancer treatments, a patient is seen by several providers. You see a medical oncologist, you have a surgical oncologist, you have a radiation specialist, all of this. If the results of the test is so critical, what role do each of these physicians play in helping the patient to make the best decisions possible?
So really, all of these members of the team, it's like being on a baseball team. You have a pitcher and a catcher and a first baseman and a shortstop. Everyone plays a role.
Yes.
You don't expect your catcher to come out and pitch. You don't expect the shortstop to run in and do the job of the catcher. Everyone plays a role, and you work as a team. And that's how we work at the Cancer Center. And so our job is to do the genetic counseling and testing. And when we do it, we write the patient a letter and interpret their test results, and we send a copy of that letter with their permission to each of their providers. And then we actually have a meeting once a week to discuss all the patients who we're seeing with breast cancer, and every member of the team is there, and they give their input. So I would advise people what the best course would be based on genetic testing. The surgeon would talk about the best surgical decision. The radiation oncologist would talk about the radiation that would be best fitting. The oncologist makes the decisions about chemotherapy. So we all play a critical role.
Now, that's the tumor registry meeting?
It's the tumor registry, or also called tumor board.
Tumor board, okay. What happens if the surgeon disagrees with one of the other specialists?
And sometimes we do disagree with each other, and that's actually very helpful. That's where growth comes in as a team, because you explain your different points of view, and usually everyone gets their point of view on the table, and we come to a consensus. It's important to have different points of view. You wouldn't want one person making all the decisions.
Okay, and so it's not a matter that someone wins.
No, I mean, we all win if the patient wins. That's the goal.
So the patient gets the input from all of the different people. So the patient doesn't just hear from the surgeon who is going to be doing her surgery, but she hears from the medical oncologist. When they all get your report, what feedback does the patient get, and from whom?
Everyone gives the patient their own piece.
Oh, so the patient is getting input from 4 or 5 people.
Yes.
And he or she then has to take all that information and get it. It's hard to pull information together when you have been told you have cancer.
I agree with you.
It is very difficult to hear what is being said.
I completely agree. And in an ideal situation, your team is communicating, and they've already come up with a treatment plan that they think would be best for you. The patient may have some decisions to make, like, yes, I'd like to do chemotherapy first, and then surgery, or surgery first and then chemotherapy, or I'm interested in preventative surgery, or I'm not. But if the team is communicating and they come up with the plan that they think is best, I think it makes it much easier for the patient. Okay,
in that case, let's deal with breast cancer. In that case, when the team, come together and discuss this, is that information, whatever the consensus is that communicated to the patient by the medical oncologist, or is it, you said it, each person tells the patient, but as I said, it's very difficult for the patient to remember what was said by each person. And this again is where I would say to my audience, it is very important that if you're going through a critical time in terms of your health, that you have someone who can be your eyes and ears, a backup system for you, and be a good advocate, someone who understands how to navigate the medical system. Healthcare today, as I know it has improved because we have all these specialists, and when someone only has one area to concentrate on, he or she is going to be better at it because they can go more in depth and they have a smaller sphere to deal with. However, the patient has to deal with all of those different specialists. I strongly encourage everyone who is going through a major illness, and even if you're not going through a major illness, to have someone in your family or a loved one, a friend who you trust and have and whose commitment you can be assured of, to take the journey with you through this process and be very honest and straightforward with that person. Share your fears and concerns and whatever history you can about your family with this person, so that that person can help to answer questions for you when you have to go to the doctor. Because a friend of mine told me about 6 years ago he was diagnosed with prostate cancer, and he said when the doctor gave him the news, he left, and in driving to his job, he didn't see or hear the traffic. He said it was like he had left, it's like his mind had left his body, and his body was functioning, but his head was someplace else. And I think that happens to so many of us. So it's really important that you have an advocate and or a support person, system with you to get the information and write things down. When you have a question, write it down on the date that you have that question, or if you have another appointment, write all your questions down on the date of your appointment. Take your little notebook with you and ask the doctors the question you have.